Thank you for a kind presentation, and thank you to the Congress Committee for this invitation. Actually, I will talk about the story, but also of the evolution of the corneal cross-linking. And these are my financial interests, actually. And what about the history? Everybody knows that probably cross-linking was invented by Professor Theo Saylor. And the legend tells that once upon a time he was in his Swiss dentistry office, and he looked at the UV light of his dentistry that was photopolymerizing their capsule, and then he started to think if this could be applied also on the cornea. But this is not the truth. The real truth is that all the innovative things are discovered in the US, and the first trace of corneal cross-linking is this. In 1970, Cannon, Foster, and Chase start to describe what the relationship between the age and the collagen oxidation in the cornea. And then in 1990, another American researcher said it demonstrated the application of the mild reaction of a corneal collagen in a diabetic patient. And this is the base of the concept base that after a lot of years will concern about the clinical application. So cross-linking essentially is a chemical physical process. We have a natural cross-linking that is age-related. We have a pathologic cross-linking in the diabetic patient. But now we're going to artificial cross-linking that is a chemical physical process. Which are the sites? The sites are the intrahelical cross-linking, the collagen fiber. So we have a cross-linking intrahelical, interhelical, and a fibrillar collagen cross-linking. And after the US, we just start the story how we know. And the stories of clinical application start with the Professor Saylor that started the first clinical study in 1998, and they published these 2 Miller Stone works that actually have more than 10 years of basic science history. Why use riboflavin? Because riboflavin is a photosensitizer. It is responsible for singlet oxygen production and the reactive process of cross-linking. It's a light filtering. It confines the cross-linking just to the cornea, not to endothelium. And the riboflavin has not direct cytotoxic effect on keratocytes. Why riboflavin? Because we have also a glutaldehyde cross-link that's toxic, but we have also a good aldehyde sugar cross-linking, but we care about patient, but 14 days is too much for surgery. So this is basically the reaction. We have a riboflavin, the spread of the cornea. We have irradiation. We have a combination of these 2 factors that produces an oxygen radical that create a cross-linking effect. This is the first clinical study, human study, that was performed in 2003 by the same group, Wallens, Expel, and Saylor. And this is the dogma. This is the Dresda protocol. It is actually what was used since now. Essentially, we have a 1-hour procedure with a 30 minutes of soaking with a dextran riboflavin 0.1%, and then 30 minutes of irradiation at 3 milliwatt per centimeter square at 5.4 joule of energy. This is the base of all cross-linking research, the stress-strain test. Basically, we take cornea, we take lamella, and we do a stress-strain test that show how, respect to the normal cornea, we augment the stiffness. We have also other effects for cross-linked corneas. We have the increased resistance to enzymatic lysis. We have also an increase of denaturation temperature. And this is what really happened in a real cross-linked cornea. You can see the compactation of the anterior lamella with respect to the control. And this is the real effect. What about Italy? Italy started the clinical study after about 6 years, and the School of Siena was a leader in this. He also take the cross-linking into the market because they was responsible for the production of the first market riboflavin. And that's important because we go over the galenic production. They was also responsible for the first prototype of cross-linking machine, and they built two. This is the 5-lead cross-linker. And finally, with the CSO, that is a company of Florence, they built the first commercial cross-linking machine, the CBM. What about the present? There is a lot of a hot topic, other indication for cross-linking, protocols, machines, riboflavin solution, epi-off or epi-on, and we'll talk about this. The present of cross-linking is that actually we have a more evidence-based science, but we have just some alchemy about the concentration, the power, the exposure, and the treatment volume. This is the first issue, the epi-off cross-linking complication. Cross-linking is not always safe. I'm speaking about dextran 20% riboflavin. We have also sometimes, if we have high volume cross-linking procedures, we have also anomalous keratitis, stromal corneal edema. And someone tried to also to find the reason. In this work, for example, they considered the age and the steepening of the cornea, and they found that very curved cornea are more prone to have a complication. The limits of the conventional procedure is that it's a time-consuming procedure, 1 hour. And if you use a dextran solution that is hyperosmolar, the cornea substantially shrink during the procedure. So we start, for example, with a 500 and we cross-link a cornea that is 300. So it's not real good. And this is the principal question about complication. I cite this work that I published also with another group in which we performed an intraoperative measurement with a conventional procedure. As you can see, the cornea during the soaking procedure, just after removing the epithelium, shrink for more than 25%. So epi-on or epi-off, this is the amuletic question. The problem is that epi-on is very safe, but probably is not so efficacious. And epi-off is for sure efficacious, and there are a lot of papers that demonstrate this, but sometimes it's very dangerous. The epithelium, actually, for the cross-linking, acts as a shield and absorbs more than 90% of the UV. And so we have a very superficial cross-link. We are safe, but we go very, very superficial. And this is not good also for surgical result. This is a review of the literature, and a part of the one work that is published by the creator of transepithelial collagen cross-linking, that is strangely very different from the other, but the other study demonstrate how and essentially the epi-on procedure does not affect nothing. And this is the reason. If we look at the confocal microscopy, we can see how in epi-on cross-linking we have a apoptotic pattern that is very variable, uneven, from the center to the periphery. We have a variable level of apoptosis, and the reaction is not so controlled, and it's just limited to the first 100 micron of the cornea. And if we look at the same result in confocal study, you can see how with the epi-off we have trace of apoptosis at more than 300 micron under the cornea, while in the epi-on we have just 44 micron level in which we can observe some trace of apoptosis. And there are also a long-term study. This is the study published in JSCRS, which showed how after 2 years the transepithelial crosslinking in another demonstration does not affect the cornea. If we look at this study, you can see also about in best corrected visual acuity, the epi-off group by the time goes well, and the epi-on group by the time it goes very bad. And all these patients was retreated. 90% after 18 years old was retreated. This is really important because also if we look at the morphofunctional correlation, we can see something in the epi-off, as you can see also in the confocal microscopy, and the patient after the epi-off crosslink doesn't see well for a month because we have a reaction. On the other hand, the epi-on procedure, the patient see very well immediately after the procedure, but by the time it progresses, his keratoconus progress. In the epi-off procedure, we also have what we call the corneal push-up effect. We have a centralization of the cone, and that's because we have substantially a flattening of the apex. How to enhance the riboflavin penetration through the epithelium? There is a lot of study, and what I found was interesting. Was the work of the Charles Gdaya that disrupted the cornea. So I decided in the work that I will show you to use the epithelium surgical disruption plus the solution of riboflavin with a chemical enhancer like EDTA, trometamol, and back. And so I published this study in JSCRS last year, in which I substantially demonstrate how with this technique and the conventional cross-linking I have a good result, more respect to the epi-on but less respect to the epi-off. But this was really safe, and that was I did for 2 years before I switched into the new machine. Why epi-disruption? Because we enhance the penetration of the riboflavin through to the stroma, and we preserve an epithelial net that guarantee a faster reepithelialization after the surgery. I will show you this technique rapidly, and you can see the corneal pock marking. And then I use a solution of riboflavin with the EDTA, trometamol, and back. And then I perform, in this case, an accelerated cross-linking, pulsed because you can see the light goes on and off. Another good technique, if you perform the normal cross-linking, is the epithelial island cross-linking. In other words, you can leave an epithelial island beyond the thinnest point of the cornea, just to preserve this zone, because you don't want to go deeper where the cornea is thinnest, and cross-linking the epithelialized cornea in the periphery. And we have accepted this work, and definitely the things goes well with the old technique. And this is another arm another arrow that you have on your back. We have also a good morphofunctional correlation with this technique, but now is the time to starting to look at the future of the cross-linking and how we can modify the cross-linking. We can modify the UV power, the soak time, the riboflavin concentration. We have also, I will show you the topographic application. And the first problem was how to solve the corneal shrinking. We published this work in which we observed the riboflavin solution without dextran, but with HPMC, that is substantially isoosmolar. And we started because we have a suggestion from lab, and as you can see in this sample with a rabbit cornea, if you use a dextran solution, you will have a substantial shrinking by the time. If you use water, you will have less shrinking, but by the time the cornea shrink. And if you use a dextran-free solution, the cornea substantially is flatter during the whole procedure. That's the reason why I started to have a clinical study that is going to be published. I performed the intraoperative OCT with a dextran-free solution. As you can see, after epithelium removal, about 50 micron, the cornea substantially stay flat with respect to the whole procedure, in which that goes on over 1 hour, in which the cornea shrink that more than 30–35%. And what about the new cross-linking machine? The new machine can allows you to choose a lot of energy power modulation from 10 milliwatt to 45 milliwatt, and they have also an optimized beam profile that is very, very important. This is the reason. Look at the left picture. This is a conventional machine with a flat beam. You have about 8.4 milliwatt in the central 2 millimeters, but if you go to the periphery, the energy drops down to 3.7. So you have a very uneven exposition to irradiation and less cross-linking in the periphery, and you can see the demarcation line that is flat in the periphery. With the new optimized beam, we have a more consistent delivery of energy throughout all the cornea. We have an improved cross-linking in the periphery. Why this is important? Look at this paper. This paper is really a milestone. It shows how normally, if you have a central keratoconus with the older machine, you will have a good improvement. And if you have a keratoconus that is very peripheral, you do not have this improvement. This is just because with a normal machine, you gave a lot of energy in the center, not in the periphery. And the keratoconus normally is a peripheral corneal ectasia. Shortening the procedure is possible by remodulating the diffusion of riboflavin, using, for example, iontophoresis and increasing the effluence and reducing the UVA exposure. But you have always to consider the Bunsen-Roscoe law of reciprocity that tells that essentially the tissue absorbs energy, not power. But this is a slight bit different in the biological environment because we observed that increasing the exposure time increases the penetration of the treatment. So we cannot treat the cornea with the same result at 30 milliwatt respect to the 3 milliwatt. And actually, our experience is this: if you use a high power, you will get more superficial cross-linking. Okay, and if you use low power, you will go deeper. And I go fast. This was demonstrated by histological and confocal microscopy study. Another way to vehiculate the riboflavin is the iontophoresis. And in this study that I published last year, I demonstrate, like in OCT, you have a penetration that is better respect to epi-on, but not comparable to epi-off. So actually, we have to speak about volume of cross-linking, and these are the two laws that I already said. Another way to increase the cross-linking efficacy is the oxygen. Actually, with a machine that actually we are developing, and we tried to have a pulsed light, as you said in the video, because oxygen is the principal actor in cross-linking. So we tried to also to have from lab study we had better result, and we start with a clinical study in which we compare the pulsed versus non-pulsed, and we published this work, and we have a better result, not statistically significant, but we have a better result in visual acuity, in K average, in apical curvature. So our impression was that oxygen in this way serve as is useful. We also performed some histologic section in which we demonstrated how the more power you use, the more superficial you goes. And actually, this is the protocol that you can use with an actual machine that is very spread. The future, and conclude, is the topographic cross-linking. Actually, I'm starting with a clinical trial with this machine that allows us to give several energy into several points of the cornea, so you can just adjust the power depending on the topographic pattern of the keratoconus or corneal ectasia. And our goal is to have not only a halt of progression for keratoconus, but also a more reproducible refractive effect. And probably next Congress I will show you the early result. In some case, it really functions, as you can see now. So I think this will be the future, but we have to test it. And before announce this, we have to do a very strict first lab and then clinical studies. And thank you for your attention.
Thank you, Dr. Rechichi. We actually have time for just one question. Does anybody have a question? Thank you for that very thorough presentation, and it's very exciting technology, so we appreciate you presenting on it.